Whenever we see a case of Descemet detachment, we tend to blame the cataract surgery. But did we ever think that an underlying corneal pathology might play a role in causing the detachment? Let's see in the following case scenario. Starting with the history, a female patient 55 years old was presented with immature senile cataract. Her visual acuity was 624, that doesn't correct, and on examination she had nuclear to posterior subcapsular cataract and diffusely nebulous cornea with crocodile chagrin in the periphery. She was a candidate for Phaco emulsification surgery in the right eye, in which I started with the regular steps: 2 MVR incisions, Visco injection, and keratome incision. At this step, I noticed this line in the middle of the cornea, and when I did really focus, I understood what's going on. It is Descemet's detachment, but it was too large and involving about half of the cornea. So, I called a senior staff member who had helped me to reposit the Descemets. First, by evacuating the Visco from the anterior chamber and replacing it with saline. Then, he used the stain to visualize the movements of the Descemets precisely. After that, he did massaging of the cornea to reposit the Descemets in its place. And to keep it in place, he did Descemetopexy with a large air bubble that was introduced with monitoring of the intraocular pressure. The surgery was aborted at this point, with decision to re-operate after healing of the Descemets. 2.5 months later, our patient came to do the Vaiko surgery, and these were her photos. The cornea had shown this temporal fold of the Descemet's membrane, with the previously mentioned crocodile chagrin on the nasal side. This is the anterior segment osity of both eyes, with the detachment seen clearly on the right side. The specular microscopy had shown with a normal endothelial count and central corneal thickness. Regarding the second surgery, I've been facing multiple difficulties. First, I had to avoid making any wounds at the temporal, the superior, and inferior sides to avoid the previously detached and folded Descemets. So, these were the only available sites to create my MVR and keratome incisions, and I was obliged to do a nasal-sided Phaco surgery while having the nose as an obstacle in my way. So, here are the superior and inferior MVR incisions, with the keratome incision done nasally. I used a 19-gauge MVR and 3 mm keratome to get wide incisions in order not to squeeze the instruments against the corneal tissue and cause any new Descemet's damage. Here are the usual steps that passed smoothly: the rhexis, the hydrodissection, rotation of the nucleus, sculpting, and dividing it. Now I started to suffer from the widely fashioned wounds. I had this leak with iris prolapse, and during removal of the quadrants, I had severe instability of the anterior chamber with multiple surges that caused me to catch and repel the posterior capsule for about 3 times. So, I had to express the last piece of epinucleus with Visco in order not to catch the capsule while experiencing any surge. The IA was done. And despite all my precautions, I found this new Descemet's detachment at this point. So I implanted the IOL, then started to reposit the Descemets. And did transcorneal suturing. For an extra precaution, I've left an air bubble inside. This is the picture of the patient the second day post-operative with a slight stromal edema at the site of the new detachment. 1 month later, this had become the picture of her cornea with the detached desmates from the first surgery seen on the temporal side. The anterior segment OCT had shown the temporal detachment while the nasal side was healed. This is her refraction and eventually the best corrected visual acuity had become 6/9. Our patient was lucky with happy ending, but she rendered me to think about the cause of recurrent Descemet detachment on trivial surgical trauma in the same eye. Most probably, this is related to the presence of an underlying weakness in collagen fibrillary attachment and anchoring protein function that can only be determined through histological examination, although specular microscopy and anterior segment OCT were helpful. This claim is supported by the previously reported cases of bilateral and delayed onset Descemet detachment post-cataract surgery. In 2013, Chalchi et al. Had reported one case and studied the characters of 12 cases previously reported in the literature. In conclusion, Descemet's detachment is a complication of cataract surgery in which Descemetopexy can be done with the use of air, gas, or transcorneal suturing. Although surgical trauma has always been considered as the only cause, but the underlying corneal pathology can also be a predisposing factor. Thanks a lot for watching.